Welcome to the Health Leader Forge, a joint production between the University of New Hampshire and the Northern New England Association of Healthcare Executives. My name is Mark Bonica, and I am an assistant professor in the University of New Hampshire's Department of Health Management and Policy. If you were paying attention to the news about the COVID-19 pandemic in New York City, you'll remember that 2 Army field hospitals deployed to provide support to the beleaguered healthcare system there. Today's guest is Lieutenant Colonel Jarrod McGee, commander of the 11th Field Hospital. In this podcast, we discuss what a field hospital is, what its capabilities are, and what it's like to move one from Fort Hood, Texas, to New York City with only a few days' notice. This interview focuses mostly on the logistics of the movement to give listeners a sense of what it takes to accomplish something this complex and make it look easy. In the full-length version of the interview, we follow the discussion of the 11th Field Hospital's mission with a discussion of Lieutenant Colonel McGee's career. He started out in the Army as a combat engineer, running around the woods and blowing things up, as he said, to later getting a commission as an Army Medical Service Corps officer and becoming a health services comptroller. So he has had a varied and interesting career. He is also the Army Regent for the American College of Healthcare Executives. So we talk about the importance of professional organizations and how his ACHE contacts actually helped provide him intelligence as he brought his unit into New York. We conclude with a discussion about leadership. I hope you enjoyed this interview with my friend and former student, Lieutenant Colonel McGee, and if you do, won't you please leave feedback on iTunes, Stitcher, SoundCloud, Google Play, or wherever you might be listening to this recording. It helps other people find us. Thanks for listening, and here is Lieutenant Colonel Jarrod McGee. Welcome to the podcast, Colonel McGee.
Thanks. It's good to be here.
So you recently completed an unusual deployment leading the 11th Field Hospital to participate in providing support to the city of New York in the Javits Center. So people probably saw this on the news, kind of made national news all over the place. But before we kind of get into the actual experience, I'd like to, for the audience, to talk a little bit about the unit that you lead and get a little bit of background on what that is. So what is a field hospital?
So first of all, let me just kind of open with this real fast. Just keep everything on the right side of legal for me. Anything I say, not views of the Army, right? My own opinion.
Sure.
And if I speak of any individual organization, I am in no way of endorsing that organization.
All right.
Just using them in name. So thank you.
All right. Fair enough.
So a field hospital, the best way to think about it for your listeners would be picture a hospital that you have in any one of your cities. So an acute care and trauma hospital. That's what we are. We are a modular 148 bed acute care and trauma hospital. The only difference with us is this 148 bed acute care and trauma hospital, we can box up and load onto trucks or trains or boats and ship it anywhere in the world at any time.
So when you say acute care hospital, like what capabilities do you have? What kind of treatment can you do when that hospital is fully set up?
So just like your local hospital, we can do everything from primary care and physical therapy, social work services, the full complement of behavioral health, all the way up to emergency medicine, neurosurgery, CT surgery, you name it. Then, of course, the full complement that goes along with that. I have full complement of ICU nurses and ICW nurses, medics, all the ancillaries that go along with it. We have full pharmacy, we have full lab, radiology capabilities, everything you would find down the road. But the difference is we're self-contained. We have to provide all of our own power and water and food and all that internally. Yeah.
So, I mean, that's kind of amazing. And so you say you put it in boxes and send it someplace. How long does it take you typically, if you were to take the hospital, the full 148 bed unit and out into a field environment, how long does it take you to normally set up to full capacity?
So, well, number one, we're always ready, right? So we're always packed and ready to go. we can deploy anywhere in the world as fast as we can get our stuff loaded onto vehicles to move out of Fort Hood. It takes a big team effort from a whole lot of folks back here and a whole lot of folks on the receiving end. But yeah, we can get out the door and as quick as we can load vehicles.
So let's say you're loaded and your all your boxes have been put down and wherever it is you're going to be. When would you be ready to take patients?
We actually just did a validation exercise not too long ago. By doctrine, we should be 100% ready to go in 72 hours. But
okay.
we beat that by about 35 or so percent. We had full ED complement set up, ready to go in less than 18 hours, and we were fully mission capable not long after that.
That's pretty amazing. So from boxes on the ground to a 148 bed facility ready to take patients in less than, you said 18 hours for ED capability, and then sounds like less than 2 days for full on capability. And that's assuming you're going to provide your own power, your own water, and all that as well. Like that's kind of amazing.
Seeing everybody get to work on it is nothing. The coordination that it takes, everything from, imagine building a building, they have to start with staking out the land to figure out the dimensions of the hospital, where each individual tent is going to go, to having everything up, including lights and water. It's a dance that we should time lapse it just so everybody can see, what it looks like with people running everywhere and forklifts and tents and, trucks. And it's a sight to behold for sure.
So 148 beds, how many people are we talking about when the unit is 100% staffed?
Just over 300 people in just the field hospital.
And you say just the field hospital. So what else could there be around you then?
We fall under something called a hospital center, and a hospital center. You can think of it like a 26 person or so command and control node. So for your listeners, think of that as like maybe a regional headquarters, a regional C-suite, where you have a CEO and a COO and a chief nurse and a chief doc, and then the administrative staff up there to support. And then underneath that, you also have my organization, the field hospital, which has its own C-suite. But then you also have some outlying clinics that fall underneath that hospital center as well. For example, our hospital center here, the 9th Hospital Center under the command of Colonel Dave Hamilton, has 2 forward resuscitative surgical teams, a behavioral health detachment, and a veterinary surgical services detachment. So our hospital, then working in conjunction with them, we won't all be co-located, but if we were, now that organization balloons to over 500 people.
Okay. Are there 2 field hospitals under the hospital center? Or is it just one?
There is only one, but by design, the hospital center can provide command and control, or whether you want to call it mission command or command and control, or C-suite oversight of 2 field hospitals. So
okay.
Yeah.
This is relatively new doctrine, so it's come into play since after I retired from the Army. So I'm learning as we talk.
Yeah.
Okay, so you said 300 or so people actually assigned to your organization, and then we talked a little bit about the hospital center and some of these other organizations that roll up under the hospital center. So thinking of your organization, thinking of the field hospital and the 300 people you have there, the model as it was back in the day when I was involved in still in the Army, we called it a PROFIS model, a professional filler system model, where if you were assigned to a field hospital, for example, you would spend most of your days working in a fixed facility, a brick and mortar building hospital, and you would get pulled over to the field hospital when the field hospital went on a big exercise or actually got called up to deploy. Is that still the model with the field hospital, or how has that changed?
So it's similar. So I have organic staff here at the field hospital, but then we also have like the PROFA system, the professional filler system that you were just talking about. We have something similar. We still have a bunch of docs and nurses, around the world working in different military medical treatment facilities. The difference is now are those providers are actually assigned to us. So if the call goes up that I remember I mentioned that we were modular. If the call goes up that we need to deploy either a certain module of, like, say, just the ICW of the hospital, I want to deploy 60 beds someplace, which we actually did recently. The call goes up for those people assigned to that 60-bed detachment. Those people show up, and it's the same people that since they're assigned to us. So those providers and nurses, they come, they fall in with the same teams they're used to training with. They fall in on the same equipment that they're used to training with. And then the only difference is the location that they may end up serving. So that's how the new model is a little different.
So you mentioned that you have docs and nurses who are assigned to the field hospital, but when the field hospital is not actively engaged in an exercise or a deployment, they're working at a like I said, a fixed facility. So you're at Fort Hood, so I could imagine they probably work at the hospital at Fort Hood when they're not with you. What's the idea behind that? Why aren't they just full-time assigned to you so that you could just take them and go?
So I can actually expand on that a little bit. We're at Hood, but not all of my folks are at Hood with us. I've got folks down in San Antonio. I've got our CT surgeon. I think he's out of Tripler right now, out of Hawaii.
Okay. So Texas to Hawaii. All right.
Yeah, but the idea behind it is for our providers to maintain those clinical skill sets that they have to use in wartime. They get those skills and maintain those skills in our fixed facilities. So they stay there and they provide services to the beneficiary population there. But then when it's time for deployment, we call them back and they go with us.
So you talked a minute ago about the field hospital itself is modular, and you mentioned you had like a 60-bed. So the whole hospital is 148 beds when it's in its full capacity. What kind of arrangements? So you mentioned a 60-bed. You could push out a 60-bed subunit. Like what are the examples of the different arrangements that you could potentially deploy without deploying the whole organization?
So we have a full capability 32-bed component that can push out emergency medicine, OR capability, and recovery in ICU and ICW, along with ancillaries. We could push that 32-bed early entry capability all on its own. That's our headquarters, what we call a headquarters and headquarters company. They can go out all on their own. We have a 60-bed ICW that I spoke about earlier that we actually, funny enough, we actually deployed it not too long ago. They picked up and went to the National Training Center in California. And as an example of modularity, got plugged in to one of our sister field hospitals to do a training exercise down there. So you can, we have that detachment. We have a medical augmentation detachment that'll provide dentistry and psychology and physical therapy services. And then we also have a surgical services, a medical augmentation detachment that provides another OR suite and those capabilities as well, the recovery capabilities, ICW and ICU. And we also have a head and neck surgical detachment as well on top of that.
Wow. So all these things so it sounds like they could deploy by themselves and they could be carved off from your organization and attached to like you said, another field hospital or maybe some other medical unit.
Exactly. They can go in support of somebody else if they have to.
Okay. So we've talked a little bit about the organization, its remarkable capabilities. So I'd like to talk a little bit about your recent deployment up to New York City, of all places. I imagine you probably never thought you'd get orders to go to New York City in your current role when you took over.
Yes, it's funny. It was my first time in New York City.
That's one way to
there.
Yeah, that's one way to see it. Okay. So you're a healthcare leader. You'd been in command for a year. Is that correct?
1 year last month. We actually had our first birthday for the 9th Hospital Center and the 11th Field Hospital in the Javits Center in New York City on April 16th.
Okay.
Yeah.
So it's a brand new unit as well. That's great.
It is.
So, I mean, as a healthcare leader, I imagine you were monitoring the crisis closely. At what point, when did you really, as a leader, when did you become aware of the pandemic? And when did you and what was your first kind of, when was it first discussed with you that your unit might be called on to go provide service there?
Yeah, as in healthcare, I'm sure, with you and all of your students and all of your listeners, people were paying attention to the news. Started seeing, this virus seems to be spreading pretty quickly across China, and look at that, across the borders. Oh, look, it's starting to expand a little bit more. And I think it was about the middle of January or so, if memory serves, that it was declared a public health emergency of international concern because it was crossing those borders. So at that point, we started doing a bunch of research on, okay, what does it mean to get this disease? What does that do to a patient? And then as we started getting those reports, we would start sharing them with our providers across the world and talking about it internally. Just kind of getting our head around it. Okay, should it come to us? What is it that we're going to have to do? What is it that we're going to have to be ready for to take care of those folks? And then we actually got, I think it was around March 18th, we got notified of a potential deployment, and those locations were either East Coast or West Coast. So we were thinking, okay, maybe Seattle or New York, maybe somewhere in California. And then at that point, we really started that planning. Okay, what would it look like for us to go ahead and pick up and move out to one of these places? And then the next day, the warning order actually came. So we ended up getting the warning order less than 24 hours after we were notified of a potential deployment.
Okay, so I know this terminology, but let's talk a little bit about what does that mean? A warning order. What does a warning order mean in the military?
So that says, okay, you're going to do something, right? You're going to do something. So get all of your stuff in order and get ready to go. That's what that means. It's you can maybe call it a heads up, like somebody walks into your office and they're like, hey, heads up, this is getting ready to happen.
All right. So it's a very formal heads up.
It's a very formal heads up.
Okay.
That's probably the best way.
But at that point, and the purpose of that is because not all the logistics have been worked out yet, not all the decisions have been made about the details of whatever's going to happen, but to kind of make sure people are starting to prepare to do something.
It's hopefully gonna give you that kind of the situation, the mission, some command and signal stuff, some service and support. It's gonna hopefully throw out the 5 W's for you: the who, what, when, where, why. Not necessarily the how, but at least get you started.
Okay. So we're in the middle of March 18th, 19th. You've now gotten some formal notification. Yes, this is going to happen. So what do you start doing when you get that warning order as the commander of a field hospital? You've been alerted through the warning order. What are the first things you start doing to prepare your unit for this mission?
So, like I said before, we're always packed and ready to go. So at that point, it's really just a matter of coordinating all of our support agencies so that they can start picking us up and getting ready to move us wherever it is that we need to be. Whether it's going to be on trucks or trains or boats to get us to our destination. And then that goes along, that's just the equipment side of it, right? So that's in the grand scheme of things, that's relatively simple. the biggest thing that you want to take care of is all of the medical and administrative processing for your soldiers, right? For the staff. And that's everything from making sure that everybody's medically ready to go. Say something like everybody's got 90 days of medications on hand if they have allergies or something like that, to making sure that everybody's wills are up to date and their powers of attorney are set, so that their families can be taken care of back here, mom and dad back here, or husband and wife can take care of the family with, certain legal actions if they have to, all of those things. Those are all the pieces that you put in motion. The other thing is just all the locking in all the internal planning. Okay, all the concerns. Do we have all of our supplies on hand that we've asked for? Is it all loaded and ready to go? All of those pieces and parts. That's the process put in place.
So, at what point did you get the details of where you were going and what you were going to do and who you would be working with?
Yeah, so we got the notice on the 19th, that real formal heads up, the warning order, and then it was on the 24th that the deployment order came down. Said, all right, hey, you're going to go to New York City, and we actually launched our advance party early the very next day on the 25th. Yeah.
Okay.
Yep. So we get the formal heads up. Something that goes along with that, like I said, is making sure everybody's stuff is ready to go. So then when we got the actual deployment order, the very next day, those people are ready to go now. They get on the plane and they took off to New York City. They actually stopped en route and picked up a second field hospital's advance party in Fort Campbell, Kentucky, picked those folks up, and then they continued on to New York City. Then we ended up pushing out our main body, the biggest part of the force. We pushed all of our medical folks early. The main body deployed just one day after them on the 26th.
So how was the mission described to you? Like, what were you told? This is what you're going to New York City. What were you told you were going to do?
So we knew we were going to New York City, and we knew we were going to provide a relief valve to the local hospitals in New York City, but we did not know what that was going to look like. We didn't know if we were going to be, operating a shelter like what was initially started at the Javits Center, or if we were going to be setting up, our field hospital. And I mentioned we picked up that other field hospital on the way. We didn't know if we were going to set ours up and then they were going to set theirs up someplace else, what those locations may be. All we knew is we were going there to provide relief to the hospitals of New York City. That's what we knew. A lot of the planning was actually taking place on the aircraft on the way there.
Wow. Okay.
We have a great picture of three of our principal staff folks. A guy named Major Pete Kirkendall, Chief Polite, who's our engineer, takes care of setting up all that power and water stuff that we were talking about. And then one of our critical care doctors, a guy named Major Sean Shirley. We got this great picture of them huddled around a map and a computer on the airplane, figuring out where they could set the hospital down, in the middle of Wall Street, on a pier, something like that.
Wow.
Yeah. So that's what we did.
Wow. So you were on your way, you sent your advance. So that was the advance party you mentioned, I assume.
It was.
So, so how many people went, in the advance party? And you said they picked up with another field hospital. So how many people were you sending in that advance party, roughly?
I want to say we had about 25, 26 people in that advance party. I may be off, plus or minus a few. But the purpose of those folks is to get there in advance, hence the name, and then set conditions for the arrival of the main body. So they start getting all the logistics in place. Where are people going to sleep? What are they going to eat? Things like that.
And those are all. I mean, they sound mundane questions, but I mean, you're showing up in the middle of a pandemic in a big city. Those are not insignificant issues, right? You can't do the mission if you don't have places where people can eat and sleep.
It is a highly complex mission for the advance party because when I say finding out, setting conditions for people to arrive, that's not just where people are going to eat and sleep for sure, right? That's all right. Where are we going to set up the hospital? What kind of patients are we expecting to see? What's that volume going to look like? How are we going to get our supplies? Who do we link in with to make sure we get resupply when we need it? All right. What about food? What about fuel for all of our equipment? They set up all of that. How are we going to get patients in? How are we going to get patients back out when it's time to get them out of here? Those are all things that the advance party starts working through on the way in and when they get there. Yeah, it's really complex.
So they're arriving, or they're on the plane making these plans. At what point did you get told, yes, you are going to be in the Javits Center? And how did that change your planning process? So
when we actually we found out when the main body was en route, we knew we were going to start at the Javits Center. That wasn't to say that we were going to stay in the Javits Center the whole time, but we knew we were going to start setting up and staffing in the Javits Center. But we still didn't know exactly what that was going to look like, because the mission did evolve from day one till we redeployed. The mission, kept kind of evolving as the conditions on the ground changed. So we knew that we were going to go in and operate in the Javits Center, but initially it was kind of set up like you would expect to see a shelter, with the FEMA setup, like something akin to maybe following a hurricane or a natural disaster. That's kind of what you would expect to see, and that's really what we started falling in on. Then, of course, that evolved from there.
So you started falling in on the Javits Center. So what was your understanding as you arrived? And you said the mission evolved. So what were you told? Okay, go ahead and set this capability up. And then how did it change over time while you were there?
So we were there in support of federal and state agencies like FEMA, U.S. Public Health Service, and the state of New York. So we were there to provide support to them. So it started, like I said, with we had something called inclusion and exclusion criteria. People who you acuity of patients that you'll allow into the facility, and then people who we weren't going to allow into the facility. And that actually started out pretty strict. But then as you start seeing the demand signal from local hospitals change to say, hey, we need to discharge people that are, say, maybe COVID convalescing patients, people who still need, let's say, and I'm not a provider by any measure. Say we have people who need, say, 6 liters or so of oxygen still. They're not necessarily out of the dark, but they're definitely recovering. These are the people that we need to get into the Javits Center so that they can free up, they being the local hospitals, can free up more ICU space. So then our mission set started evolving, right? We started then taking those patients with higher acuity. And then once we saw that we needed to bring in some patients with even a little higher acuity above that, it kind of evolved again. And we set up our own ICUs within the Javits Center with all the things that you hear about, like, ventilators and monitors and stuff like that. That's how it evolved from day one until about the middle of April is when we hit peak capacity, or peak census, or rather I should say, at the Javits Center. And all that happened over the course of about 2 weeks. We went from 2 patients to our greatest census was over 450 people. I think we made that move from 2 to 450 in about 12 days or so.
Wow. So so what were the assets on the ground? You mentioned FEMA had kind of started setting it up in the center. Were there other providers, other in the facility already? Were there other medical units of from the state or from or were you guys the providers of care?
No, we did not do this alone. This was a whole of government approach to attacking a crisis. So you had civilian agencies in support. You had U.S. Public Health Service, which is another uniformed service.
Okay.
They're in support. You had reservists got activated. You had the Navy there. The Air Force was there. National Guard was there, in full force, working. It was, like I said, we weren't the only one. It was a whole of government approach and a giant team effort.
Yeah. So talk about that team and how that all was managed. And I realize you probably you were not in charge of the whole thing, obviously.
Clearly.
Well, maybe not obviously I know. Yeah.
Clearly.
But so how did you fit into that process? How was that process managed? And let me see, how did you fit into that whole process? Let me put it that way.
So we brought, all the medical capabilities to bear that we've already spoke of. And then there was also another field hospital there out of Fort Campbell, Kentucky, like I mentioned. Those folks actually fall under our sister brigade, which is the 44th Medical Brigade, and they come out of Fort Bragg, North Carolina. So the 44th Med Brigade commander, Colonel Kim Aiello, she commanded the entire task force. Which we named Task Force Silver Dragon. So that was great because we had two different medical brigades. You had the Silver Knights, 1st Med Brigade, commanded by Colonel Rob Howe, and then the Dragon Medics out of the 44th Medical Brigade out of Fort Bragg, commanded by Colonel Aiello, both combined together. So we named it Task Force Silver Dragon. So the 44th Med Brigade commander was the task force commander, and we were placed under her. So we operated in support of all those other agencies under her mission command.
So so you mentioned a whole bunch of other government agencies. Were they all under Colonel Aiello?
No. So everybody was there in support under the guidance of FEMA, Health and Human Services.
Okay.
And then in cooperation, so with the state of New York, right? So that,
okay.
Yeah. So that was their big operation.
Okay. So she oversaw the Army component, the two field hospitals, as well as what else? So what else kind of?
As well as the other organizations I spoke of. So we ended up getting Navy assets and reserve assets as well. And then those folks ended up working in both the Javits Center and in local hospitals in New York City. To make her job even more complex, she was the task force commander for the entire eastern seaboard from I think it was Maine to Florida. So all those other regions. So, wow. Yeah, so she was mission commanding folks going out and setting up alternate care facilities in multiple other cities in Jersey and Philly. So, what shaped your decisions, or the overall, not your per se, but the decisions, the policy decisions as to what kind of patients were going to be allowed in, how long were they going to be kept there? You kind of talked about you went from 2 to 450. So clearly there were changes over that period of time about who you would take care of and for how long, I assume, right? So so what did that look like? How did it change over time? So the driving factor there was simply the demand signal. We needed to provide the supply, right, that the local hospitals needed. If they need to free up ICU space, then we need to take some of their recovering patients so that they can focus on those more acute patients. That's what drove it.
So you were up to a census of 450. So you had, at one point, you had as many as 450 patients under your care. At what point did the census start to drop, and what was driving that?
So our peak census, I believe, was 453. That was the high point, and that all happened around 15 April or so. After that, we started to see the census drop. And if you compare that with kind of the curve you would see in New York, it follows that a couple days, right? Which makes perfect sense. You have fewer people coming into the hospitals. They're able to decompress, right? So they're able to treat more of their folks, less people then coming to us, which means then our intake is going to start falling off while our discharges continue. We expect to see that number come down. And that's exactly what happened.
As a leader going into this situation, what were your main concerns? What were your going in, and how did that change over time?
So my two principal concerns rolling into this were people based. Number one, what's going to happen to what's going to take place with the families back here? Because like I said, if soldiers or sailors or airmen for that matter, if they can't focus on the job at hand because they're worried about the family back here, then they're going to be less effective. So that's one of the principal concerns is, have we done everything that we can to make sure families are taken care of back here? Do we have the support structure in place back here to make sure those folks are taken care of? And then the second concern are for those people that we were taking forward. So, and that covers everything from force health protection. Like I was never concerned over, are our folks going to have, things like the protective equipment required? I was never concerned about that because I knew we had. I was never concerned over anything like, will they have the discipline to wear the PPE properly at all times? I was never concerned over those things. My big concerns were, okay, at what point are we gonna start overstressing that force? Are we going to be able to give them appropriate work rest cycles? Are we going to be able to get them some type of step away time from the floor to let them recover? For whatever that period of time is, are we going to be able to do that? So that was my number one concern. It's how do we take care of the people who are taking care of the people?
So you said you weren't concerned about protecting your soldiers from the virus, but that seems like that. Were you doing testing of your soldiers? How did you know? Because the virus is such a tricky virus that we're dealing with, where we have a lot of situations where people are asymptomatic. How did you know? How did you feel comfortable that your soldiers weren't getting sick themselves?
So when I say I wasn't concerned about what I said is when I'm not concerned about protecting them from the virus, I'm not concerned with them having the functional materials on hand. Like, do we have masks, and do they have the discipline to wear their masks appropriately? I was very confident in their ability to stay safe from the virus while they were treating patients, because we had a very deliberate donning and doffing protocol for them to follow. So everything was overseen step by step to don your PPE and doff your PPE when you were entering and exiting the floor. So, for example, if I were going to walk on the floor, I approached an entryway that was maintained by people dedicated to a station to get me in my PPE properly. So they would sanitize my hands. They would instruct me to, put on my gloves. They would sanitize my hands over my gloves again. They would instruct me to put on a mask. They would sanitize my hands again. You know what I mean? So they would walk us through the entire process of donning gloves and masks and eye protection and gowns before we even entered the facility. So once we were in the facility, then you could move about and treat patients. I never treated a patient. Again, I'm not a provider. But for our providers and nurses, they would go in and they would treat patients. But then when it came time to leave the floor, they would go through that reverse process again with a single dedicated individual to a person, walking them step by step on how to get out of their PPE safely without infecting themselves.
Wow.
It was very deliberate.
At what point were you told, okay, we no longer require your unit services, prepare to redeploy? And what was that process like once you got that notification?
So once we saw the peak census and we started seeing it roll off, and then we started seeing the census and local hospitals start to roll off as well. We knew at that point the decision was going to start coming for us to redeploy part or all of our force, or would we have to redistribute them elsewhere, or would we actually get ready to go to, say, some other location in the U.S.? Those are all things we didn't know. So as we started kind of drawing down from the Javits Center itself, we started preparing for a follow-on deployment to another unknown location.
So there was a possibility that you weren't going to go back to Fort Hood and back into kind of prepare mode. You were potentially going somewhere else.
We didn't know. So all we knew is that we were drawing down from the Javits Center. But like I said, all right, where could we end up next? So kind of stay frosty and get ready to go somewhere else in the world.
Okay. Because at that point, we didn't know if there'd be a large outbreak someplace else. I mean, there was looking back now, it probably feels like we knew more than we actually did at the moment.
Hindsight, right?
Right. It's always,
we can look back and we totally could have known. But no, of course not. There's no way we knew. There's no way we knew what the quote battlefield was going to shape up to look like.
So eventually you did. So I guess the census continued to drop. At what point were you told, okay, you're going to go back to Fort Hood? I assume you did. That was the next step. You went back to Fort Hood, or did you actually go somewhere else first?
No, we came back to Fort Hood. So we discharged the last patient 1095, out of the Javits Center on May 1st. So it was after that point we started getting ready to go someplace else, or like I said, or potentially go back to Fort Hood. We didn't know. I want to say it was about maybe about a week or so after that. I don't remember exactly the date that we got notice that we would be coming back to Fort Hood. But at that point, we started preparing to redeploy by testing our folks and putting them in quarantine and making sure that they were good to go, getting all their flights, ready, and getting those folks set up to come back home. Then tearing down all of our equipment and sanitizing all of our equipment and getting it all boxed up and inspected and then getting all that ready to come home safely as well.
So one of the things is a great lesson that I know that we learn. Now me speaking as a former military person, one of the things we learn right away in our leadership training is that is the art of doing an after-action review, or the need to do an after-action review, or what we call an AAR. And this is a strength, I think, of the military. That we learn from exercises like this. So I'm curious, I'm sure you had some sort of AAR process after this was over. What lessons did you learn as a unit from the deployment? And what would the unit do differently if you were presented with a similar situation in the future? And what did it do well?
So you're absolutely right. It's critical to capture lessons learned when they're fresh in your head, and then think about how you're going to actually exercise those lessons in the future. So I think the phrase we like to use is lessons learned, not lessons observed. So, okay. So the biggest, we talk often about being flexible and maintaining flexibility and execution. We actually, and the military is actually really good at that. I think people have an idea that things in the military are very rigid, and that's true to a certain extent. But the folks in the military are very adaptable. And that's actually the biggest thing that we got to see in execution here. The difference here was the flexibility and execution with folks who don't wear our uniform and who aren't, kind of embedded in our, hierarchy and in our culture, in our cultural hierarchy. So the biggest thing is that I noticed was how do you get in where you fit in with people that you're not used to working for, and those people are not used to working with folks like you. That was the biggest lesson learned out of here is how do you do that yourself? And then how do you foster an environment that lets other people do that as well? That's the biggest lesson that I get into this.
Can you give a specific example of how that went well, or and what you might what other organizations might learn from your experience?
Absolutely. Some of the biggest things I saw were allow people to function outside of their quote traditional or maybe predetermined role if they have a certain skill set to bring to bear. So if you have a person who is in function X, but they have a skill that can really be used somewhere completely outside of their lane, well, you know what? Maybe that's the place for them in this operation. Maybe you find that other thing that they're good at, or you let them find it for you and let them bring it to the table and say, hey, boss, I've got the ability to do this thing and I see a need for it over there. Do you mind? No, absolutely. Go do it. That's the biggest thing is you have to be able to kind of hold on loosely, let those folks go out and let them run.
So you made it back. You brought all your folks back. You're all back now, or are people still deployed individually, or?
So we ended up deploying also. If you remember back to us in the beginning of this conversation, the 9th Hospital Center has some other subordinate organizations. One of those is a behavioral health detachment. They deployed as well in support of this operation, and they were out there working with our folks to make sure everybody was doing well, and they were also out there nested in the hospitals because remember, like I said, there was the sister field hospital was operating mission command over folks who were working in local hospitals. So our behavioral health folks were out there working with those folks in those hospitals as well to making sure everybody was kind of staying sound of mind. And those folks are getting ready to come back here in the next day or two.
Wow.
The 44th, the task force commander still has some folks up there as well. So I know they're still operating, but I know that operation is slowly starting to collapse. Well, I guess I should say, I don't want to say collapse. I want to say it's slowly starting to be drawn down and moved out of it.
Okay. Great. Well, I know what an amazing experience that must have been to be there and support such a difficult time in really in our nation's history. It's kind of an amazing opportunity, and we're lucky that you and your unit were able to be there.
It was hopefully a once in a lifetime event, and what I mean by that is hopefully we never have to see anything like that again. But wow, did you get to see the humanity? It's amazing what happens when so many different people come together and work towards a common goal that has such an importance. It has such a huge impact. Not just on your organization, but on the community. So it was inspiring. It was really inspiring to be part of it.
Well, so I want to shift gears a little bit because normally in my podcast, I usually start with career stories first, and then we talk about your current assignment. But I wanted to start with your current assignment first because it's so fascinating and timely. But I do want to talk a little bit about your career. So you mentioned, you're not a provider. So I'd like to explore a little bit about, how you came to be the commander of a field hospital. And I was looking at your CV, and it looks like you've got a couple of different phases to your career. And I thought maybe we'd run through that with you. it looks to me like you started your career in the military as a combat engineer. Is that correct?
That is correct. I started out as as an airborne combat engineer in Fort Bragg, North Carolina, in the Army's rough terrain parachute company.
Wow. What drew you into the Army, and why engineer?
So my grandmother drew me into the Army. I wasn't supposed to be in the Army. I was supposed to be a rock star. Didn't work out. I was actually working graveyards in a truck stop, a couple blocks from the house in New Mexico. And I remember I came home from work one morning, and I was living with my grandma, and I walked through the front door, and it's this really small house. So you walk through the front door, and you're in the living room, and then you can see right there to the table, to the breakfast table. And I opened the door, and I stepped inside. My grandma was sitting at the table with the recruiter.
Okay.
So I took the hint, and I was like, so I guess I'm taking the ASVAB today, and so the rest is history. Took the ASVAB, and I had no idea what I wanted to do. I was at the entrance processing station, and they were just kind of showing me the videos of all the different jobs, and of course, I'm a young guy, and they showed me a video of a guy running around in the woods and blowing things up, and doing all the cool stuff, and man, I was sold. So,
yeah.
So he's like, "You want to be an engineer?" I'm like, "Heck yeah, sounds great." It's all the funny stories that you think about when you hear about somebody enlisting in the Army. I was like getting ready to sign the paper, and one of the recruiters comes, or the career counselors, I think they were called, comes running around the corner yelling at me. He's like, "Stop!" So I kind of looked at him, and then he puts his hand on my shoulder, and he's like, "Do you want to go airborne?" And I'm like, "What does that mean?" And he's like, "So you get to jump out of airplanes and blow things up." Heck yes, sign me up. so that's what started phase one for sure. That's all
right.
All kind of luck.
So was it everything was it everything the advertising made it out to be?
It was a really great job. It opens a young man's eyes a little more to the world. Definitely instills a sense of discipline that you may have been lacking before, for sure. So yeah, it was. I had a really, really good time. A lot of fun memories from that first part of my life, first part of my Army life, anyway.
And then now you didn't stay engineer. You actually transitioned to be a lab technician.
I did. So it's kind of like the situation with my grandma. I've been really lucky. I've had a bunch of people in my life take care of me. I don't know if I'm inherently lazy or something. They just I need a lot of nudges. So I was gonna get out of the Army and go back home, and ended up having a talking to by an NCO, a sergeant. Who wasn't even in my squad. He was in the next platoon up. He was in first platoon. And I remember his name. His name was Joe Queen. And he came in one day, and we were sitting in the company area, and I was getting out of the Army. I was less than 90 days out. And he was like, "Oh, so what are you going to do?" And, I told him I was getting out and going to college. And so he asked what college I was going to. And, I told him I hadn't signed up yet. And then he asked me if I had taken the ACT or SAT yet. And my answer was, no. And so I remember him, he just looked at me and he was like, "Well, good luck with that." And then he got up and he walked away. And that was, so I took that hint, and I got up and I walked down the sidewalk to the retention NCO, the reenlistment sergeant, and told him, "Okay, I'll reenlist if you get me a good school." And he got me the lab tech course. And so I reenlisted to become a lab tech.
Well, so why was that a good school?
So it,
What were you thinking?
so it gave, at the time, I don't know if it still is, but at the time it was affiliated with George Washington University. So you were able to go to this, it was a year-long training. So you were able to go to this year-long training and come out of it with 60 semester hours from George Washington University. So it was a huge jumpstart to my academic career. So that's what was really appealing to me at that point. I was like, okay, if I'm not on the ball to sign up for college on my own, like Sergeant Queen pointed out, then you know what? This is a great stepping stone that moves me in that direction that I was intending to go. That's what drew me to it.
Okay. All right. At what point did you eventually got a commission and became a medical service corps officer? How did that come about? So you were there, you had done I assume you'd finished your training. What was the next step there? How did you earn your commission?
It took another nudge. It really did. It took another nudge. I was in the middle of my commitment from that reclassification to lab tech. And I actually had a civilian supervisor at the time. And he brought a flyer to me one day. And the flyer was advertising a program called the Green to Gold program. And that's a program in the Army where you essentially get out. At the time, you actually got discharged from the Army. That's changed. That doesn't happen anymore. But you get discharged from the Army and you go to college full time, and you go through a Reserve Officer Training Corps program, and then when you're done, you get your commission. So she brought me the flyer advertising what's called the Commanding General's Hip Pocket Scholarship Program for Green to Gold. And she was like, "Hey, have you heard of this?" And I was like, "Yeah, I'll take a look at it." And I really wasn't interested. I was kind of set on, I'm getting out of the Army again. It's time to go. A couple months later, she brought the flyer to me again, and was like, "Hey, I couldn't remember if I talked to you about this. Have you seen this?" And so I went home and I thought about it, and I said, why not? But at that point, I had there was only about a week left to the application deadline. So in that week, I had to get accepted to a college. I had to get all the medical evaluations done. I had to get letters of recommendation, written. So I was hustling. I was hustling for a week. Put in my application and ended up getting selected for a Commander's Hip Pocket Scholarship, and then ended up going to college and got my commission into the Medical Service Corps out of there.
Now, did you had both engineering background as well as healthcare background at that point? Did you ask for Medical Service Corps, or did you was that just luck?
No, that was my first choice.
Okay. Yeah. What was it that made you decide you wanted to do that?
So having worked in kind of the medical area then at that point, I started developing a passion for it. I knew I wasn't going to be a provider. I was never moving down that path. But for healthcare leadership, it was really starting to appeal to me. So I think you're about a year out from graduating from college when you have to kind of pick the core that you want to go into. You had to, at that time, you had to rank order. I think it was 16, the 16 cores. You had to rank them from first to last. And then you had to put a combat arms somewhere in the top 3. So I chose Medical Service Corps. I think I chose engineering second. And then I don't remember the list from there on down. But yeah, so I got my first choice, got what I wanted, and became a Medical Service Corps officer.
Okay. So you kind of first 5 years as an officer, you did some platoon leader time, you had company command, kind of the usual stuff. How much enlisted time did you have?
I had just under 6 years. Is like 5, let's say 5.5 or so.
Okay. So I'm looking, so again, I'm looking at your career, doing some of the things the early careerists do. so you would have had 5 years enlisted, 5 years, let's say 5 years through your company command. You're pushing 10 years. That's usually kind of a decision point. At what point did you decide for folks to stay in the military or call it a day? At what point did you decide that you were going to make the military a career, meaning to go 20 years or more?
So once I got my commission and I started seeing, the potential and the rewards really from operating on that side of the house. When I say rewards, what I mean is the reward of actually getting to work with people and lead people, and then the potential of shaping policy. When I started seeing that, I was in my head, I was like, yeah, this is for me. This is what I want to do. So that's what really kind of cemented it. I was kind of think what we were talking about earlier is get in where you fit in. And I felt like I was fitting. I felt like this is something that I want to do. I feel like I have something to bring. And I love being on the team. I really enjoy being on this team, and it feels good to put on the uniform every day and walk into this environment, wherever it is. So I knew then, I was like, it feels right.
So you've had this kind of your early career. You kind of had this, and so it seems sort of throughout your career, you've kind of done the kind of back and forth between, field units where you're going out and, like you said, blowing things up and running around the woods, to being in a hospital as a lab tech. I assume you work in a clinic of some sort, getting your commission and spending time with the infantry. And then being it was a training command, I assume, that you had.
It was.
Yeah.
It was,
yeah. So an interesting kind of back and forth. How did you wind up getting your first exposure to financial management? So you wind up at Tripler. How did that happen that you wind up doing that work?
So I guess this is becoming a theme. Much like in my life, it took a nudge. It really took somebody sitting down. I didn't want to do finance. It took somebody sitting me down and explaining to me what it meant. So I had the vision in my head of the finance person is the person who wears the green eye shade and sits there
right.
With a calculator that has a long paper ribbon running out the back of it, and I was like, yeah, that's not for me. I don't want to spend the rest of my time in the Army balancing somebody else's checkbook. It's just not what I want to do. And my boss at the time, I was a battalion operations guy. And my boss, the executive officer for the battalion, was a guy named Colonel Scott Cooper. He pulled me aside and was like, "Oh, you have it so wrong. Let me talk to you about what it really means to be a healthcare CFO." And he opened my eyes to it a lot. And he actually ended up getting me into my internship. And then I just got really fortunate, and I did my internship at Tripler in Hawaii, which was amazing.
Okay. And I was in the same office once upon a time. So, yeah. So you did this what we call an internship, and that kind of brought you into the healthcare finance subspecialty within the Medical Service Corps. You went on to do CFO, Chief Financial Officer and business operations for 3 different organizations, the last being one of the Army's larger medical centers, Womack Army Medical Center at Fort Bragg. So back to Fort Bragg again for you. That's a theme too. So what's it like? So you've had this great experience. Well, I'm feeding that one in because I was the same as you back in my Army career. So what was it about being a comptroller, about being a CFO, doing this kind of work that you really liked? What was it that sold you on the field?
I had a really good experience in my first account. So when I came out of my internship at Tripler, as you know, you get your first standalone account, hopefully. And I got picked up to go to Bavaria Medical Activity in Germany, and I saw in that position, I saw the potential of the office of the CFO to really help shape military medicine. So again, it's always about the people you end up working with. And I ended up with two fantastic deputy commanders for administration, which is for folks listening, that's the kind of the COO of the hospital, and then the hospital commander, the CEO. They really used the office of the CFO as an integrator. So there was the first COO, the first deputy commander for administration, the DCA there, was a guy, now his name is Colonel Tom Bunt, followed by a guy named Colonel Scott Stoko. Those were my two immediate bosses there, and they really used that office of the CFO as an integrator. It was somebody, as opposed to just dealing with, certain aspects of healthcare and healthcare finance, they used that position as what it is. It's something that touches every other piece of the organization. So it really opened my eyes to the possibilities and the capability of that office to shape military medicine moving forward. And then all of those guys were enabled by the commander of the hospital, Colonel Rob Goodman, who really helped, kind of shape that whole organization. And I tell you, that team did some wonderful things. That's what really solidified it for me. That's what really made me love being a healthcare CFO.
You've had this kind of really interesting career where you started out as as an engineer, and then you became a lab tech, and then you did platoon leader time with the infantry, and then you did some, you did all this great finance stuff. How does that lead you to be now as the commander of a field hospital? I mean, how does that all lead to where you are now?
Well, first, I don't want people to get confused. I was never an infantry platoon leader. I was
sorry. Did I say that?
No.
A medical platoon leader supporting the infantry.
Yes.
Yeah.
So they have an infantry battalion has a medical platoon, and then I was the medical platoon leader for that. Had a wonderful group of people there as well. That's another thing that helped shape it again. I mean, just you get to work with these amazing folks that let you see, wow, this is what I want to do. How did I become a hospital commander? So I ended up applying for command, and I came out on you either get selected as a primary to be a commander, or you get an alternate slot, or you get non-select. So I was actually fortunate enough to get selected, but I was selected as an alternate. So the interesting thing about it is as you know, when you come time, when you start getting close to what you think should be your retirement time, you start having very difficult conversations, with the people you love. So I was talking with my wife about it, and I actually decided to retire. And I was like, okay, it's been more than 20 years. It's been a great time. The Army's been very good to me at this point. I really enjoyed it, but it's probably time to go. So we had decided to retire, and I had asked what our personnelists, the S1, to send me my retirement packet to go ahead and get started on it. And it hit my inbox, and then 2 days later, my phone rings. And my wife at the time, she was living in Savannah. I moved a lot. So my wife was living in Savannah. I was living in North Carolina. And she was up visiting me. But anyway, my phone rings at about 10 o'clock in the morning, and it was the CG, the commanding general down here at Fort Hood. And he's like, hey, Lieutenant Colonel McGee, congratulations. You're going to come command the 11th Field Hospital at Fort Hood. And at this point in my head, I've got a retirement packet to fill out in my inbox. I've already had the difficult conversation, with my wife to decide that it's time to go and that we're going to get out. And so I talked to the general for about 20 minutes or so, and then hung up, and I was like, hey, honey, we need to talk. And so we spoke about it for quite a while. Because I almost declined it. Because we had already made the decision to retire, but decided to go ahead and take the opportunity. And I gotta tell you, I'm really glad that I did. This has been one of the most rewarding and fulfilling jobs I could ever think about. That's how I ended up being a hospital commander. I was fortunate enough to get selected, and I've had some fantastic support, around me to really enable me to take this job.
So let me ask you to talk for a minute, kind of in general, about how the Army works with those kinds of jobs. Like you mentioned a couple of times as you were telling the story about your deployment to the Javits Center, that you weren't a provider. So you're a finance guy. You have some lab experience, so maybe you go and play in the lab every now and then. I don't know, just to mess with them. No.
Oh no.
You're not allowed. Okay. So, why? How does the Army decide who to put in charge of a hospital?
So there's a centralized board selection process. So you apply, you kind of throw your name in the hat and say, yes, I would really like to compete for command. And then at that point, meaning the board, remotely goes through your entire record from front to back to determine if you are a good fit, somebody that they would want to place in a command position. And you get rank ordered in there. So you get picked to take command.
What are they looking for? It's obviously not that you're a provider, right? So this is a hospital, you're in charge of a hospital, but you're not a provider. So, I mean, like, obviously it wasn't the most important thing that you could actually treat patients.
Right. They're looking for your leadership potential. They want to see if you have the ability or the potential, right, to move into an organization and take charge of it and foster a positive cultural environment and lead that organization forward. That's really what they're looking for. They're looking for the best person to fill that role.
Well, congratulations on that and getting that role. And it sounds like you've had some really amazing experiences. I'd like to close on a little discussion about leadership, since we're just talking about that. So what would you say is your leadership philosophy?
When I was putting together my intro brief for this command, you want to put together, hey, this is who I am, and this is my view of the world. When you come into an organization, just kind of give them that heads up. This is the kind of person that at least I see myself as. When I focus in on like what do I really think my leadership philosophy is, it's I want to be the kind of person who provides intent and end state, and then just let the ponies run. Let people surprise you with what they bring to the table. I smile when I think about it, because in my head, what I picture is, I have an old photo of my dad teaching me how to ride a bike. And it's that picture where, the kid's on, wobbling on the bike, and the dad is behind me, and his hand is out like he just let go of the seat. So in my mind, I don't even know he's there, but he provided intent and end state. Hey, I want you to be able to ride the bike, and I don't want you to wreck it, and I want you to, ride it that way. But he was there, behind, kind of providing stability, oversight, providing some top cover, some safety and security, and then you just, let me go. And that's kind of how I try. Albeit unsuccessfully, I'm sure, more often than not. That's how I try to run an organization is, hey, here's the intent, here's the end state. I'll protect you as much as I can, but get out there and run. I'll watch over it and make sure things are going the direction I want, but be free and run.
That's cool. That's a nice metaphor too. So what do you look for when you are evaluating leaders?
I look for like if I'm evaluating somebody to come into an organization and be a leader, or if I'm evaluating them on the performance of their job. First thing, if I'm bringing somebody in, I'm not necessarily looking for the best person. I'm looking for the right person. I want to bring somebody into the organization who will nest with our team. I want to work with people who aren't here to push their own agendas. I want to work with people who are free to offer and accept assistance. Those are the kind of folks that I like to bring on board. Now, when I'm evaluating them, all right, how well are these people using their attributes to kind of foster that in the people that they are leading? Are my subordinate leaders nurturing those whom they have ultimate responsibility for? And then from the technical side of it, okay, are you using those capabilities to their fullest extent to be successful? Are you achieving the results that we expect of you? So are you doing it? Are you getting done what needs to get done? And are you doing it well in a positive environment?
A question I like to ask successful leaders is, can you give me an example of a difficult leadership lesson that you had to learn the hard way? So we know you're successful. You've done a great job. You've gotten to where you are. But is there something along the way that you had to learn kind of by making a mistake?
How much time do you have? I have all of the mistakes. One of the biggest things that I reflect on often is number one, I can never pretend like I know everything. I think I've said it a lot. I've been really, really fortunate to stand on the shoulders of some really, really good people. I've been fortunate to have a lot of support from other folks. So the first lesson is I do not know everything, and there's no way that I could ever know. And I think the one of the biggest lessons that I reflect on often, as a young officer, especially like in my company command, I feel, I was successful, it was a successful command, however you want to define success, but I don't feel like I was. I feel like I missed a lot of opportunities as a young officer because I didn't nurture the way that I really try to nurture them. So when I came out of company command, I was reflecting on the last 2 years, and I was like, I spent 2 years in command, and I could have done things a lot differently, could have been better. And I think the biggest mistake, to get to the question of what mistake did you make, the mistake was empowering. I failed to empower to the level that I should have. I felt like I needed to have way more control over what was going on around me than I really did. So the biggest failure was I should have just provided a little more, intent, insight, and oversight, and again, let the ponies run. So I should have done, and I don't think that I did. Definitely not to the extent that I could have.
So it sounds like you've taken that to heart, since it was an important part of your leadership philosophy now.
I hope so. I hope it's a lesson learned and not a lesson observed.
You mentioned a number of folks along the way that gave you nudges. So I wanted to ask you about your thoughts on mentorship, and what does a good mentor do, and how does that fit in with your thoughts on leadership?
So I think a good mentor is somebody who not just nurtures the positive attributes in you, but I think a good mentor is somebody who can identify your shortcomings, and then you talk about nudging. there's somebody who can alert you to your shortcomings and maybe help push you in that right direction. Maybe it's a certain skill that you require that you're not comfortable with exercising. So maybe a good mentor, maybe that's somebody who can help push you, into that uncomfortable situation while providing some oversight, providing some safety and security for you, and let you swim a little bit to develop those skills that you need to shore up a little. I think that's something that a good mentor does. There's somebody that helps you see yourself and then helps you become a little better to think about it a little better tomorrow than you are today.
I don't want to end the conversation without talking a little bit about your role with ACHE, with the American College of Healthcare Executives. So you are the Army Regent for the American College of Healthcare Executives. What is that, and why is it important?
So yes, I am the regent for ACHE. I want to be very cautious. I need to make sure that I'm not endorsing a specific organization. There's certain Army ethics rules that I need to stay on the right side of. Right. But I am the regent for the American College of Healthcare Executives for the Army. Mm-hmm. Why do I think it's important? Number one, I think being a member of a professional organization, whether you're in uniform or out of uniform, is for number one, developing the network. But the biggest thing that comes from the network is being exposed to people with points of view that are different than your own. So you can find a lot of people share similar problem sets, in life. They face similar challenges, maybe in different locations, but similar challenges. So getting exposed to people who kind of tackle those problems, to solve those problems, in different ways, I think it's invaluable. I think that's one of the biggest things that comes from being a member of a professional organization. It's about being a master of your craft. It's, I can't become, better at what I do if I stay in my bubble. I need to get out there, and I need to talk to other folks who are in a similar field. Heck, I need to talk to people who don't even do what I do, just so I can kind of expand my horizon a little bit.
And is that important so let me set aside, to be fair, let me set aside ACHE specifically and just let's talk professional organizations in general. How important is that for early careers? So I'm thinking about my own students who are young folks getting ready to enter their careers. How important is that for people at an early career stage to get involved with organizations like ACHE, but you could throw in MGMA, HFMA. There's a whole laundry list of great organizations out there.
I think as an early careerist, somebody just starting out, getting involved with those professional organizations, the biggest takeaway from that is you are going, whether you want to or not, you are going to find some people to mentor you. You're going to get exposed to people who are more than willing to help you out. Even if you're not looking, somebody's going to find you. And somebody is going to offer that's what comes from professional organizations. And most of the time, the people who are going to find you and offer you assistance are the same people who required assistance when they were at your point, when they were just starting out. They can see things that you need that you may not know you need yet. And that's why it's important. You can get so far ahead of the game and learn so much before you're faced with something that you don't have a clue how to handle. That's the biggest thing that you're going to get at that early career stage. Then to take it a step forward, when you're moving on in your career, you now have somebody that you can call when you need help, because you're going to need help at some point. You now have somebody that you can leverage to help you through a difficult time. I can actually tie this back a little bit to the operation at Javits in New York. When we got the first notice that we could potentially deploy in support of COVID operations somewhere in the U.S., the first thing I did, outside from getting the unit ready, one of the first things I did was I picked up the phone. Well, I picked up the email. I picked up the phone and I called the ACHE network. That just happens to be the organization that I'm closest to. I picked up the phone and I called everybody. I shot an email out to the CEO, to all the other military regents, the regional coordinators. I was like, hey, we may go somewhere. I might need some help. And within 5-10 minutes, I started getting email replies. And then next thing you know, I'm getting a phone call, and I got connected with one of the CEOs at one of the local hospitals in New York. And then I'm on the phone with him, starting to develop medical intelligence estimates to get an idea of what's going to go on the ground. Those are the kind of things those professional organizations and those networks do for you. Some of those conversations were helping drive, early, capabilities decision making, at least part of the planning process. You can't get that from Google. You can't get it just from a textbook. You have to get that type of stuff. Can only be brought from relationships, and that's what you get out of a professional organization.
So, last question for a young person thinking about a career in health. Why should they think about a career in military medicine?
So I can't think of a better way to learn that level of teamwork and leadership than in the military. And there's a reason I say that. I'm not saying you can't learn teamwork and leadership outside of the military, but you learn it in a different way when you're wearing a uniform. And it doesn't matter whether you're working in a fixed facility, like a brick and mortar hospital, or if you're doing medicine out of the back of a vehicle, what we call tailgate medicine. If you're leading tailgate medicine as a platoon leader, the level of leadership that you learn in uniform is ultimate responsibility. When you're in uniform, you not only have responsibility for everything that your organization does or fails to do, you have ultimate responsibility for the care and well-being around the clock of the people with whom you serve. I can't think of another place that gets you that deep into somebody's life with that level of responsibility, aside from being a parent.
Colonel McGee, thank you so much for your time today. It's been great to catch up. And I forgot, you kind of threw a bone out there and I didn't jump on it. And that was, you really were going to be a rock star at one point, right? Was that was the plan at the beginning?
I was not going to be, but in my
that
head,
was the plan.
Oh, and in my head, it was, we were on our way.
Yeah. Grandma had other ideas.
Yeah. Fate, life, whatever you want to call it, something jumped in and moved me in this direction. And I'm happy. I'm really happy with it. Maybe afterwards, maybe that's the next life.
It's not too late. Maybe that's the next phase, right?
Yeah.
All right. Thank you so much for your time, man.
Yeah, I appreciate it. It's good to see you.
You've been listening to the Health Leader Forge, a joint production of the College of Health and Human Services at the University of New Hampshire and the Northern New England Association of Healthcare Executives. Please go to our website, healthleaderforge.org, for more information or to leave comments about today's podcast. Look for Health Leader Forge podcasts on iTunes, Stitcher, SoundCloud, and other podcast distribution sites. Thanks for being a part of the Health Leader Forge community, and we'll talk with you again soon.